Okay, Dr. Rachel Fobert, I am looking forward to this discussion with you on this beautiful Friday. And I've really enjoyed getting to know you in the community and just hearing more about everything that you do. And I'm hoping before we get rolling into this conversation about constipation, that you'll share a little bit for the listeners, a little bit about yourself.
Yeah, of course. Thanks for having me. I am a registered naturopathic doctor, and I run a general practice, which means I kind of see everything from perimenopause to painful periods to IBS and constipation and kind of anything in between. So I am pretty well versed on the human body and how everything kind of interacts together. And as a naturopathic doctor, I get to treat with lifestyle and nutrition and habit modifications, sometimes supplementation when needed. And depending on the province or jurisdiction that you're in, sometimes we can use pharmaceuticals. So that's kind of how I approach my care. And then I also do have a private online coaching practice where I see women across the world for their constipation. So this is how I got into talking about constipation so much. And I've truly heard anything you could imagine about constipation at this point. So I enjoy talking about it because I think it's a little bit of a black hole sometimes in the like healthcare community, that it's nice for patients to hear that there is an understanding of the condition and there's more to be done.
Totally. And I think that's why, like, when we were putting together this episode, I thought it was most important that was like, I really want a resource that, like when a client comes constipated, or that's one of their symptoms, or something that they bring up in their intake form, that I can give them this for some enhanced learning. Because I think most of them have just heard, like, you need to eat more fiber and drink more water and don't strain. Like, that sometimes, like, all they're told. And so I think some people will be surprised, like, how are you going to talk about this topic for so long? And so, yeah, and so like I said, I look forward to having a resource to be able to give people a little bit more information. Can we start
For
with the
sure.
complete? Go ahead. I cut you off from something there.
Oh, I was just going to say it's such a good point because if a little bit more fiber or more water or more walking was going to get rid of the constipation, then you actually would not fall under a diagnostic criteria of functional constipation or IBS. So that kind of advice is for the general public that might have a bit of a slowdown because maybe there's a nutrient deficiency occurring. That's not the same as what you and I will kind of be talking about of those people coming in with chronic conditions that are trying to manage it long term.
Yeah, exactly. So let's just go, like, strip it back to the basics here. What is constipation, and like what makes somebody like, not what makes somebody petty, but what qualifies them as being constipated?
So there's a couple diagnostic criterias if you kind of like get into the nitty gritty of it. But essentially, there are three things that can occur. You can either have IBS. If you don't have IBS, then you have a functional constipation. And if you have one of those two things, you can have a defecation disorder, which means you also have trouble evacuating the bowel movement when it's at the end of the tunnel, as I usually say. So, what this kind of looks like in your real life or in your body would be about 2 times a week. So, it doesn't have to be every day, but about 2 times a week, we're maybe having more pellety bowel movements. So, they're dehydrated and coming out smaller or in clumps of pellets. And then the other one would be a reduced frequency. So maybe we're missing a day or two. The diagnostic criteria is you need to be having 3 bowel movements or less a week to be considered constipated. But there's other things that come with that. So straining gets included in this. If you are straining with this change in bowel movements, we're constipated. If you are having to evacuate that bowel movement by either inserting a finger vaginally or rectally, that also is included in there as well. If you feel like when you have a bowel movement, it's not complete, not because you look in the toilet and say, hey, there's not a lot that came out, but it's a physical sensation of it being incomplete, that's also a big part of constipation. So if we're experiencing two or more of those that I just explained, then we kind of funnel you into, hey, you're constipated. And then we're just trying to figure out which type. Are you IBS? Are you a functional constipation? And then do you have that defecation disorder with it as well?
And that's what, like, just to clarify, like, as a physio, a pelvic health physio, people are usually coming to us with like they're thinking of us related to the outlet problem. So, like when you list those, I'm like, I could tell you a lot of people just in the last week, for example, one lady said, "Is it weird that when I poo, I can almost see some tissue migrating into my vagina?" Um, I am smearing like every time I feel like I have a poo, but then every time I pee after I have some fecal or stool staining on my toilet paper, hemorrhoids, anal fissures. I think most people associate us with the kind of exit of the poo because the pelvic floor makes the exit. But we too are asking a lot of these questions about what's happening up the chain because, I mean, the pelvic floor is not working in isolation ever, right? And so yeah, I think a lot of people just think constipation is hard poops, right?
Exactly. Yeah. And I also think people think you have to have it all the time. And I think it's
Hmm.
important to mention it's like that almost 2 days a week. It doesn't even have to be a full 2 days a week of you having those symptoms. And that's enough for us to say, hey, there's a problem here. So it's a good point to make is it doesn't have to be happening all the time.
Hmm. Well, and I think if you were to next describe to people, like, because there's a lot of people that, when they come in and you ask them these questions, I find that they pause a little bit and like kind of, well, what do you mean? What are my poops like? Or because that's all they've ever known.
Yeah.
Right? Like sometimes if it's all you've ever known, like nobody looks at anybody else's poo. This is not something we talk about in conversation. So can you describe to people listening, like what is ideal poop? Like what are we aiming for?
Good question. I call them like the unicorn poops or that like text
Hmm.
picture perfect bowel movement. But there's a couple like physical parameters that we're looking for. So the length of that bowel movement that you're evacuating is going to represent how strong your colon contracted to push it out and how far your colon contracted. So ideally, I like to know that a full sigmoid colon contraction has been emptied. So that's about a foot in length that we are aiming to try and pass, which is really important to actually look in the toilet and take an idea of what came out. And then we also care about the hydration of the bowel movement. So the more pellety and hard your bowel movement is, the less water there is in it. The more liquidy and watery, the more water is in that bowel movement. So we care about hydration a lot, and this is the Bristol stool chart. If I know you've probably talked about it in your practice, but for those listening, the Bristol stool chart is just a visual representation of if your poop is dehydrated, overhydrated, or perfectly hydrated. And it's a really easy Google, but we're looking for a 3 to 4 on that Bristol stool chart to represent a nice hydration of that bowel movement. Those are my main parameters when I'm actually looking for what's in the toilet. And then I'm also just making sure that people are noting we don't have a ton of undigested food in that bowel movement. Corn, of course, is okay. This is a normal one. We can't digest the cellulose in corn, so it's normal to see that one in your bowel movement. But if we're seeing like kale or a lot of stuff in that was in your meal, we don't want that. And then also we're looking for no mucus, no blood, no abnormalities. So that's kind of my main unicorn poop parameter when we're just looking into the toilet.
Okay. And so how, besides looking at maybe their stool, and I'm on that note, I just made a note to make sure we add an image of or add a link to the Bristol stool chart in the show notes. But besides looking at their poo, what are some other ways that someone would know that they're constipated? I mean, you've already talked about kind of frequency of going or how often in the week, but is there anything else specific, like other ways they would know?
And are you kind of asking if bloating or gas, or there's some
Sure,
other?
like yeah, what other symptoms might they have?
Yeah, so none of these, I mean, people experience a whole wide range of symptoms, but I will say you don't need those to be diagnosed or be constipated. But because there's so much pressure buildup in the belly when we are full of poop, we then see a lot of pressure symptoms and digestive disruption happening. So pressure has to go somewhere, and oftentimes it will push upwards when we're full of poop. So that's when we start getting things like feeling indigestion. Some people will kind of get a full sensation in their throat. Some people will get a little bit nauseous, or they feel like they're not connected anymore to if they're actually hungry or full because there just is so much upward pressure happening. And then the downward pressure can happen as well. So that's when we feel that kind of like bloating by our hip bones is a big one as well, or the distension where you're kind of looking down and going, hey, my belly's pushed out. This isn't my norm and I can't do up my pants by the end of the day. That's kind of some of those downward pressure pieces. And then I know you work with a lot of that as well, because that's where a lot of the pelvic floor stuff will come in too, because we're getting so much downward pressure.
Mhm.
So that would be the main ones. And then a handful of people will also get some digestive disturbance, again, because there's so much pressure going on in the bowels and it can be a bit of a stressful experience. So we can see that digestion dampens. And that's when maybe we're starting to eat foods that usually are fine with us, but now we're getting belching or we're getting gas or we're getting some uncomfortable bloating with those foods that we wouldn't usually react to.
It's interesting. It's definitely sorting itself out, especially since like one of my kids, just as they get older, they can manage this better and understand their body better. But I used to watch one of my kids, and you could just see like all of a sudden appetite would go down, belly would go out, you know, pee accidents. Like, and I think a lot of adults don't realize that well, you hear a lot of adults talk about why, why is my child having bedwetting and daytime accidents? And that's one of the first things I say is like, is your child constipated by any chance? But a lot of adults also don't think about that when they're, "Look, sometimes I'm having incontinence and sometimes I'm not." And so they think it's a very isolated thing. But once you ask about bowel movements, they're like, oh my gosh, and show them what the pelvis looks like and how little space there is. And,
Yeah,
picture a full rectum and then how this affects the bladder. And anyways, so
for
it's I think we isolate or we put all of these problems in silos, don't we?
we do. And that's, I mean, that's a huge piece of the problem. But I so agree that once you start asking the questions, people will be like, ah, actually, yes, that does happen to me. I always thought it was weird. One I often pick up in people is like when they're full of poop because there's so much pressure, it can feel like they're getting menstrual cramps.
Yes.
And also an interesting one that pops up frequently too. And it's nice to be able to put the pieces together for someone and give them those aha moments and actually understand a little bit better.
Hmm.
Uh, yeah, super interesting.
Exactly. So, can you talk a little bit about there's so many reasons that people can tend towards constipation? And I mean, I just think of like a couple people in the last week. Like, I mean, a lot of kids. I find it's a lot of, well, kids and adults avoiding public bathrooms. So, I don't want to go there, so I'm just going to hold it and hold it. Obviously, you're going to talk a little bit about you've talked like hydration and diet and everything. But what else? Like, what are some of the things that bring people to be constipated?
There are so many things,
Mm-hmm.
and arguably, I don't actually think we understand all of the ways that people can get constipated at this point. But some of the really big ones that I will pick up for people is their eating habits actually matter just as much or more as the actual food that they are eating. So that's a really big one. We do know that things like eating disorders or disordered eating can increase the risk of constipation. Having really, really irregular habits of just your entire day, like the sleep cycle with the eating cycle and how we're running our days, also can trend us towards constipation. Antibiotic use as well. So you'll often see kids who have had ear infections or recurrent strep throat, or people who have had recurrent UTIs and many, many exposures to antibiotics will often end up with a constipation picture. Also, if we've had food poisoning or traveler's diarrhea is another one, well, we will see people develop constipation afterwards. So those are some really big ones that are experiences or things that we can acquire. And then there are, of course, conditions like thyroid conditions that can lead you to be constipated as well as a secondary to that initial concern, like the thyroid.
So what, so then what, it's just there's sometimes it's hard to kind of like, you can't say that this all of this is going to cause this. I mean, like you said, there's so many ways that you can answer this question, but I
Mhm.
don't think that people understand how, let's say, detrimental this can be to our body. Like it's kind of sometimes like, yeah, I mean, I'm constipated, but like what does that mean for our body? What are the negative effects?
Fair. It's funny because I was actually talking to someone a couple weeks ago, and she was saying, until I kind of watched your content, I just thought this was how it was, and this was
Yeah.
normal. Of going like twice a week or missing almost an entire week. So it is funny. We kind of just ignore it or we don't notice it sometimes when we're constipated. Um, so in regards, I really am careful with kind of talking about consequences to constipation because people who are chronically constipated are extremely scared.
Hmm.
They know what's going on. They feel like nothing's working. And in their brains, it will end up leading to a lot of fear thoughts. So, one of the things I really like to talk about is that we have actually researched what are some of the consequences of chronic constipation. And we haven't really found a ton that are really big, heavy guys. So, what I'm talking about is things like risk of colorectal cancer. There's no increased risk of colorectal cancer when you are chronically constipated. And it's a big fear one for a lot of people I talk to. What we do see as a consequence to chronic constipation would be things like we see a lot of manifestations in the pelvic floor, which you end up, I think, seeing a lot in your office. And then we also end up seeing a lot of issues and disturbances in your gut microbiome and your digestion. So it's more of the active functional work of your body that we see as a consequence, not necessarily this big thing where you are now at an increased risk or predisposed to this large condition like cancer or something else. So I do want to clarify that when we talk about consequences. I don't want anyone to ever be really scared walking away from talking about this.
Hmm. Totally. And I think like if I always like to kind of mm, help people understand, like some people are like, well, I've never thought about going to a physio for constipation. And I wouldn't say, I can't think of anyone off the top of my head that's come in. And when I always ask people when they come in, um, what brings you in? Like, what made you make this appointment? Nobody says constipation. Nobody, that's not anyone's meaningful reason for coming in. It's more like, and I've already alluded to some of these raging hemorrhoids. Like oh, my bum is so sore. And I thought this was surgical, but I've heard it's related to my pelvic floor. Same with anal fissures. Prolapse, like any form of prolapse, they might come, mentioning frequency, urgency, any type of incontinence. Um, what else? But yeah, sometimes it'll just be I've been down the bloating world. Like I've tried everything and someone told me to check out the pelvic floor. Everybody's, pain with intercourse. I feel like I could go on and on, but you know, constipation comes up, but they're not coming in with that as their meaningful problem. But it literally has such a kind of downstream effect for so many things.
Yeah, I
Yeah.
agree. I mean, that's like some of the beauty of the body is that everything's interconnected and nothing works in isolation. And if you try and treat things in isolation, you probably won't get very far. And it's a really big reason why I actually see a lot of people who do come in for constipation as their main concern. And one of the first things I do is say, hey, I need you to get an assessment. I need you to get a pelvic assessment because I don't know how much it's involved in your case. And if you don't work with us together, then you're going to get really frustrated because I almost explain it to them like a tube of toothpaste. If like imagining your belly or your colon being this tube of toothpaste and the cap being your pelvic floor, if I help you squeeze that tube of toothpaste really strong, but the cap's on, nothing's coming out. And
Hmm.
you're going to feel frustrated because nothing's changing. even though you feel like you're doing all of the work. So that's where we kind of work really well as a profession together of actually getting people across the finish line here when they see us at the same time, I find.
Mhm. Can you describe for people? I always find like we don't think about the way our bladder works in relationship to our brain or how our bowels work in relationship to digestion. And like it's such an automatic function. Will you just describe to people, um, how do you describe to them how their poo moves down their digestive system and out their rectum and how it relates to the pelvic floor? Because I think sometimes when you just describe the mechanics, then people start kind of, oh,
Yes, I think one of the biggest aha moments for people is when I kind of explain that your colon, which is where your poop sits and hangs out before it's ready to evacuate, is completely functioning off of stress, or sorry, off of stretch when it comes to actually pushing a bowel movement out. So the more stretch you have, the stronger push and squeeze you're going to have to get this poop out. And when I explain that, people then understand why fiber and like adding more bulk into your body ends up being a lot more helpful to actually get things out. And it truly is just a pushing and squeezing motion. The bowels fill and stretch, and that stretch creates a reflex to push. And that same system happens across the entire thing. The part with the pelvic floor is that it actually needs to relax
mhm,
for that reflex to be triggered to allow things to come out into the toilet. And that's where I think we kind of halt and switch how we approach things, because I can help the colon and all the rest of the movement go. But that relax when things push to actually let it out is a completely different ball game.
mhm. I kind of picture that the pelvic floor almost acts like a bit of a lasso around the rectum, and that, yeah, when the rectum kind of stretches, and then you get that. Sometimes I say, that feeling you get when the turtle's head is coming out of the shell. Like people are like, yes, I know that feeling of like, I need to go. That lasso on the pelvic floor is supposed to open and allow the poo to come out of the outlet, which is muscle. But when we have lots of different reasons, you've already described kind of the consistency of your stool might play a role. Plus, if you've held a long time and been constipated for many years, that can affect the stretch of the tube, right? Like the tube may be kind of like almost overstretched, right? And so it's not as sensitive to stretch. But also, sometimes we get so much in the habit of holding, whether it be because we don't like the public bathroom or it hurts. Like that's another reason why a lot of people hold is because, like, oh my gosh, this is going to hurt. This is going to hurt. This is going to hurt. So they hold. And then that muscle that's acting like a lasso will kind of not let the poo come out because that's how cool our brain is. If we don't want to go, our brain's going to try to tell our muscles to tighten. But then the poo almost gets sent back up the system again because it's like, this is not a good time. Go reverse, reverse, reverse. And then it reverses and it sits in there because the signal goes, right? The signal goes. It's kind of like, okay, not going to happen. But then more and more fluid gets taken out of the poo. It sits there longer. And sometimes I describe that like as more poo comes down, it's harder to signal that stretch. And the more in a habit we have of holding our pelvic floor, it's almost like over strengthening it. So the pelvic floor muscles get too strong, and then it's harder and harder to relax.
Yeah.
And so it becomes harder and harder every time. And so it can be, it's a very habit forming thing. And sometimes it's just the education. And so I find myself really just trying to explain that to my kids. Like, of course, go ahead and hold it. It's not a good time, but sometimes can I just explain how that works? Like if you don't go, this is what's going to happen. Yeah, but I think we don't learn about our body enough. And so I think sometimes understanding is like, oh my gosh, why didn't someone tell me?
Exactly. I heard someone explain it the other day as an owner's manual. Like, I just need an owner's manual for this thing that I have, and then I think it will help me get so much further. And I mean, all of that is so true. Our stretch reflex just gets desensitized,
Mhm.
and just see over time people get less pushes and squeezes from your bowels in general. So we get less poop that is even reaching that pelvic floor area over time. The push is just not as strong for us to be even getting an urge. And then, as you said, things start getting tense. And one of those reflexes is when your rectum drops down and relaxes, that also triggers a stronger urge as well, which when we've got all that tension, we lose that reflex too.
Mm.
So it just becomes like this tumbleweed as it goes. And I do think if people just get a full spectrum, like integrative care, they'll see progress a lot faster than if we kind of do things in silos of this person, like you only work with a naturopathic doctor for nutrition and then you're done there. So then we go to a physio. When we do that, I think people get really lost in
Mhm.
translation.
Can you explain a bit about to people kind of how routine based the bowels are? Because I know it's a very routine based system, as well as a very, isn't it? It's a very slow to change system, is it not? So can you just talk a little bit about um those pieces?
Sure. So I will actually say the bowels are quite responsive.
Mm.
So we can actually make a pretty significant change in the bowels in about 2 weeks. The problem is that constipation is actually a difficult to treat condition. And it is one of the slower ones to change because there are so many things going on. Versus if somebody has diarrhea, that will respond much faster. So it is actually a quicker to change system in general. And then in regards to habits, it's actually habits for your bowels and specifically your bowel movements and how fast things move through is based on a bit of cortisol. So, our like higher cortisol time periods of the day, calories. So, how much calories we are taking in at once, and stretch. So, how much stretch is coming with those calories, and where is that stretch in the bowels? So, one of what that kind of looks like is we have our most likely time to have a bowel movement when we wake up in the morning, because that should be our highest cortisol peak point of the day. And on top of that, we eat. So we also add some calories and some stretch into that system. So your most likely time to have a bowel movement is going to be in the morning, around 45 minutes after you get up. And then the other most likely times in which we're going to have a bowel movement and we're going to get that big push and squeeze is after a meal. So about 30 to 45 minutes after a meal that's been more than 400 calories. So this isn't going to happen when we have small snacks. There needs to be higher caloric intake there, and there needs to be some stretch, because the way the system works is when your stomach gets stretched out way up here, your system down there goes, hey, there's a lot coming in. We better empty out back here. And that's how we then get that poop and urge to go after we eat. So that's kind of our like biggest triggers throughout the day of habits. And when we're messing with when we're eating those calories, when we're ingesting that like stretch type foods, um, if we're having a good sleep and getting that cortisol spike in the morning, that's when our habits can then start predisposing us to constipation or worsening it.
What are your recommendations for like if someone has, let's say, they're describing that their stools are kind of bulky or dry or pellety, what what are recommendations for softer stools? Like, do you often start with liquid, food, supplements? Like, people always have that question, like, where do I start?
So when they're having harder pellets, what do I recommend to soften their
Yeah,
bowel movement?
softer stools. Yeah, for softer stools.
So the first thing that I always tell people is, because this is a condition that takes a long time to treat, you need a band-aid or something to just help ease things first. And that's where laxatives come in. So I will also preface this that this is after we've made sure you don't just have the nutrient deficiency constipation of, hey, you're just not eating enough fiber, you're just not drinking enough water, or you're not moving too much throughout the day. We've ruled all of that out and we've said, okay, you are truly constipated. And we know this is going to be a bit of a long haul in treating, then we will add in laxatives. And that is going to be your only quick way to soften that stool and get more stool out. Everything else with constipation takes a long time to take hold and make changes.
Can you give some examples of laxatives? Because some people will say, like, what are laxatives? Is like Restorelax a laxative? Is Senecot a laxative? Like, what are like just describe to people some of maybe the names they've heard?
Yeah, so there's lots of different types. So the laxatives that just pull water into your bowels, those are things like the Restorelax, Miralax, or it's also called Macrogol if you're in the UK. And then some magnesium types and actually really high doses of vitamin C will also do that. And sometimes people are also given lactulose. That one's often given to elderly as well. So those are all going to be a laxative that pulls water into your bowels. And then things like Senecot or Ducolax will be more stimulating to your nervous system. And then we also have a different type of laxative we call bulking laxatives because it just creates a ton of stretch in the bowels. And that will be your Metamucil that people are familiar with.
So, because people will say, like, I have everything from people that are like using them very long term to people that are terrified to use them because they've heard that they shouldn't use them. So, can you just speak a little bit to kind of how long should people use them? How much is too much?
Right. There's actually a really clear system and a really clear way in which we use laxatives, and also in a way that we shouldn't be scared. So I will say we don't have data to show there's dependency on the laxatives, meaning once you use them, you can't come off of them. I think that's the really big fear-based thing that people have. And the way that we use them is that you can't use it only when you need it. So only when you've missed a bowel movement or only when you have a hard one. You've got to use the laxative every single day for it to actually give you its best outcomes. And then we want you to use an osmotic laxative. So that was the vitamin C, magnesium, Miralax, Restorelax, Macrogol. That's the one we want you to use every day. And to make it work even better, if that one alone isn't getting you across the finish line, we'll add the bulking laxative on top. So that would be your Metamucil, that psyllium husk is what it's called. So that's the main way that we use it. And we do that every single day. The stimulating laxatives, the ones that people are really scared of, we only use them as a rescue. Meaning, if you have missed 3 or 4 days of bowel movements, then you will use that stimulating one for 3 or 4 days in a row, and then you stop taking it. Reason being is that laxative works the quickest. It takes about 7 hours to take hold. So we're using it again as a rescue because for some reason we've gotten a little bit too backed up, even with the osmotic laxatives like your Restorelax and the bulking laxative like the Metamucil in there.
So, when you say use the first options like the Restorelax and the Miralax and everything, that's every day until what?
So this is the pieces. You're going to use it every day until you no longer need it. And the way to know that you no longer need it would be that you're actually treating the underlying reason why this is happening. So the use of a laxative is truly a band-aid. It is your only quick fix, but it is very effective at helping you move out more bowel movements. They will be more hydrated and there will just be more mass. And we need that. We do need bowel movement to come out. We don't want to be waiting 5 or 6 days and then having one bowel movement and thinking that's okay. So we still do the laxative every single day until we feel that we don't need it anymore. And then we do a weaning process and assess and see where you're at. So there should be treatment going on in the background, whether it's with a pelvic physio or with somebody else for the other end of things or both while you're on a laxative.
And can you speak to, because there's a lot of people that will say, and I think this is really hard with kids, especially, they'll say, well, no, I don't think I'm constipated because like I pass something every day. But like I've heard the term log jam before, or what else have I heard? But like by stool bypass, like how do you describe to people? Because sometimes it's like it's hard, like unless you go look at your child's bowel movement, or again, people are so used to what they pass. So you can be passing something, but you're not getting the big bulk of the stool out. So can you just talk a little bit about the conversation you have when that comes up with people?
When people feel resistant
Well,
because they're
not just resistant, but they think that they're passing stool because something's coming out, but you have a feeling they're not getting the bulk of it.
right. So that's when I'm kind of explaining to people what that unicorn poop looks like.
Hmm.
That's what it actually looks and feels like to fully empty the bowels. Usually, I'm just trying to give people a picture of what we want to see so that
Hmm.
they can see where they're currently at and how far they need to go. Um, I also will get people to track because as humans, we are horribly bad at being accurate. When somebody asks us a question about what happened last month, we do a really bad job at accurately recounting that. So I do get people to track as well so that they can see it in front of themselves. That hey, you're right. I'm actually only evacuating some small pellets every day.
Hmm.
And that's not going to be enough based on how much food in bulk is going in.
Hmm. Okay. And so, where do you generally like so far? So let's just kind of think, for the listeners, I was like to try to picture the people listening to this that are kind of wondering, okay, I need to start somewhere. I think I'm constipated, or I know I'm constipated, and I need to do something about this. It's been years or something like that. Um, and a lot of times, like, do you think people bring this up to their doctor very often? And what is I want to get back to, like, I'm coming full circle for a second to the very beginning where I said, I think a lot of people just think they need more fiber, they need to walk more, and they need to have water. Would you say that's generally the recommendation we're getting, whether we Google or whether we go to our doctor? And um, yeah, like I'm trying to formulate my question here, but if
Yeah.
that's kind of what they've been given, what do you suggest as their next step? I've got a lot of things for you to unpack in there.
Right. So when people go to their doctors or like when they Google, you're right. They hear more fiber, more water, walk some more. Some doctors will give a probiotic, and they often are told to take some sort of osmotic laxative. The problem is they're really not given any direction of if that doesn't work or if you're taking the dosage on the back of that laxative bottle and it doesn't work, now what? That's the part where I think people get lost and frustrated. And usually, what I'm doing next with people is getting a full assessment of what are you currently doing that is contributing to the constipation. And while we're assessing that and working through it, let's manage your laxative so you are at least evacuating things. I give people a timeline of an entire month. It will likely take you a full month of playing around with laxatives and dosing to find the one that is right for you. And that's very common and normal. And I want them to have that expectation of that full month. So we do laxatives first while doing a nice digging assessment and figuring out what's going on in the background. And then after we've got that laxative in place at a month, then we're doing more actual changes based on what we've found.
Like what kinds of change, just some examples maybe of what other kinds of changes maybe like are you looking at with some previous clients? Just so people have an idea of what like, what that next step might look like.
Yeah. So the very, very basic first things that I will do is can we set your gut up for success when it comes to that push and squeezing motion? And the way we can set things up for success is making sure we're like poking the right buttons. And that means can we get a good sleep with a great cortisol spike in the morning? So we're working on really great sleep. We know in the data, it's not just, um, we don't see a problem only if you're waking up at night or taking a long time falling asleep. It's do you not feel refreshed in the morning? Um, are you feeling really good and alert when you wake up? Those are the things we really care about. So those are some of the basic changes we start with. And then I also start with breakfast because we know that's the most likely time that you're going to have a bowel movement. So can we capitalize on that fact and make sure your breakfast is really going to like stretch out that stomach? It's going to get you that right amount of calories and really push that right button to get the poop out. So those are some of the basic things that I will start with. And then everybody has their own personalized stuff. So it changes per patient after that
Mhm.
of, what are you doing or what is going on in your body that's contributing to this?
Mhm. And then I can speak a little bit to like if you were to come to see a physio, like if you listen to this and think, oh, I think part of my problem's at the outlet, then I mean we do a lot of work with I say too, like just like we don't think about our digestive system and we don't think about our poo moving through the system, we're not supposed to think about our pelvic floor. It's also a very automatic group of muscles. So if you've never thought about it, you're normal. But sometimes if something's not working ideally, we have to take it back a step and think about it more. And so I'll often start people with like, this is the difference between, or these are your muscles, this is where they live, showing them images, and then teaching them the difference between this is what it feels like to tighten the muscles, this is what it feels like to relax the muscles. And my homework quite often for people is go home the first time and just recognize that difference in feeling. And also, I just want you to start being a little bit more mindful on the toilet. When maybe not your phone or not reading something, but kind of notice, oh, that's me letting my poo out. That's me holding my poo in. And just noticing some of your habits around holding. And that's often where I start the first time. But then from there, maybe it does involve an internal exam of the pelvic floor or palpation, or people learn differently. And so there's never one way, but sometimes it's literally retraining because you touched on it earlier. Sometimes people have an almost opposite response to what they're supposed to. The muscles don't open, instead, they close, and then you're fighting against a closed valve, right?
Right.
And sometimes that's where you enter hemorrhoids, enter anal fissures, enter harder stools. And so that's kind of what you can expect from the physio point of view.
It's so interesting because on your end, you're really like bringing people's awareness to how much they can control their
Yes.
musculature. And what I'm doing on my end, because one of the things we know is that when people bring too much attention to their abdominal symptoms, they will actually heighten them and make them far worse. So I'm doing almost the opposite in a sense of at least trying to reframe things for people. Oftentimes people will say, oh, I ate this big meal and I can just feel so much pressure on that lower left side. I know I need to go and it just feels stuck. And I'm reframing it for people and I'm going, if you're aware of that pressure, that actually means that your gut's trying to push it out. This is a good thing. Don't put so much focus on it.
Hmm.
Or we focus on it, the more we heighten the sensation, the more we panic, the more we then loop back to impact your gut. And now we've got this like nasty looping system that's just heightening everything. So it's an interesting.
But I think it's a good point because actually, like speaking to that, you're right. Like, there's a lot of times I've done the opposite. Like, there was a lady the other day that I think she did, well, I knew she overthought everything. I could tell how she filled out her intake form. And so as we started talking, I said, kind of, how do you how is all this detailed way that you think about things? Is it exhausting? And she said, yes. And so there are lots of people that instead it's more, do you have to go? Okay, now let's set up your bathroom to be a little bit more dark, and relaxing and just go. Like, do you know what I mean? Don't think about anything. So you're right. I mean, I made it sound like there's one way to approach it, but sometimes it's the opposite. And I think that's what we all have to do is work with the person in front of us to figure out like, what does this person need? And you've said before a few times, like it's trial and error, right? Sometimes we have to just figure it out as we go because no two people need the exact same thing.
Right. No two people need the same like laxative
Yeah.
regimen, laxative dosing, same medication. It it just doesn't work that way. It has to be personalized medicine that treats constipation.
Hmm. I also think too, we are not used to talking about this and how many people are just like, oh my gosh, I would never talk to anyone about poos, but I think it serves us well as adults to learn more about this because Oh, so many of these bowel habits come from when we were children. And so
Yeah.
the more that we can recognize in our kids, like I have two kids and they're completely different bathroomers. And so they come by it honestly, but I feel like I've given them both completely different tips just so that, hey, just so you know, you shouldn't push so hard your face turns red. Like try doing this, try blowing out instead, or let's get your feet up for this one, or. And I think that we play a big role in our kids and just teaching them some of these normal things because it is so much habit formation.
Yeah. I agree. And I think also it's a lot less isolating when you talk about it because let's say, for example, if for one of your kids this did progress into something that was chronic and like the tips in evacuation weren't working, they're not going to feel so isolated in it. They can talk, they can still connect. I think it's a piece that often gets forgotten with adults that there's so much more that happens when you are constipated. Like people feel so uncomfortable in their body. They don't want to be close to their partners or be touched. People are feeling absolutely panicked about food and they don't know what to eat. So they isolate. They don't go out for dinner. They restrict their meals. When they haven't gone for days, they're panicking and taking 12 supplements and going to the supplement store. And they just don't know what to do. And I think when we just talk about this stuff, it's less isolating and we're more likely to ask for help. And
Hmm.
that's, I think, probably the most important piece of all of this.
Hmm. I'm laughing because just yesterday I was saying to one of the moms at school, I just said, "Okay, I can't come till this time. I'm doing a podcast interview." And she said, "Oh, what's the topic?" And I said, "Constipation." And my daughter walked over at that exact moment. She's like, "Mom, oh my God, so embarrassing. Can you please shut up?" And I know that it'll serve them well one day. Right now, she's
Yeah.
absolutely humiliated about what my job is, but um, behind closed doors, she's a bit more receptive. But anyways, you're right. We have to have it out in the open because it is a very taboo topic.
Right. And funny because I guess it is still a taboo topic. Like I think I talk about it so much now. And I think in our like once you kind of get into like your 30s and beyond, it becomes a little bit more normal to chat about.
Mhm.
But it's funny to remember that that still is a taboo topic for most.
Especially for
And there,
kids.
yeah,
Yeah, exactly.
yeah.
Um, Anything else that you feel like if you picture kind of the average person that you want to start them with some education, anything else that I
Yeah.
haven't asked you that you feel you'd like to get across?
Mm. I think one of the things is how do you know if you're getting better is a big one that people are often unsure of. And one of the things we didn't talk about was transit time, which I think can be quite helpful and a good starting place for people at home. Transit time is just the amount of time it takes for food to go in your mouth and then come out the other end. And we can do a really crude assessment of how long it takes by just swallowing some unchewed sesame seeds. There is a blue poo test out there where you can actually dye your poop blue and see how long it takes for you to pass blue poo. But I think that's a really great way for people to take some control and power back at home. I will actually get people to do this once a week, every single week, even when you start a laxative, because it's also a great way to know if your laxative is working. Are you passing that blue faster with this dose of laxative? Once we've come off the laxative, are you still passing that blue poo at the same rate? Okay, that's great. It means we've made some good changes. So I do think actually being able to track the improvements in a way that you have control and power over can be really helpful as well.
What does someone want their ideal transit time to be?
My what I look for in people is around 24 to 36 hours is my happy zone. I have that range because everyone's bowels are actually a bit of a different length. So
Mhm.
it's unfair to assume everyone should be passing at the exact same rate. Men and women have different length of their bowels, like each individual person has a different length. So we give it a decent range of 24 to 36 hours.
Hmm. Okay, very interesting. And so if that if that time was short, what
Mhm.
kinds of things would you be thinking? Like you'd be thinking, oh, we need to look at.
So that would be a fast transit.
Hmm.
I would assume in that case that people would have softer
Hmm.
stools,
Hmm.
would have a little bit extra water in our bowels. And we would be looking at why are your bowels pulling extra amounts of water into them? That is what I would be thinking if someone had a bit of a fast one.
Hmm. What are some of the reasons?
Mm. So usually your bowels will pull water in if they are stressed for some reason.
Hmm.
So you can actually get diarrhea when you're constipated.
Hmm.
And that is because when you are full of poop, your body is very, very brilliant and your gut will liquefy the poop behind the hard stuff. And then you will pass, it will be able to like shimmy around the hard
Hmm.
poop of diarrhea. So that's one of them if you happen to be constipated and every once in a while have some diarrhea.
Hmm.
Um, Another one is if we're just not digesting some of the components of food and these big chunks of food end up lower in our bowels, that is stressful and your gut will pull water into the bowels as well. It's another really common cause for that, like faster transit paired with a looser stool. Those are kind of the main ones that I see. And then, of course, we're familiar with if we have unwanted microbes in our bowels,
Hmm.
like if we get food poisoning or traveler's diarrhea. Again, that's stress. Your body will pull water into the bowels and try and flush it out. And you can have some of your microbiome as well in an incorrect spot in your bowels. That's also stressful and will pull water and speed up your transit time.
And what about the slow transit times? I mean, we've talked a little bit about like why poo can make a difference, but what other reasons why might our gut be slow?
So your microbiome can actually contribute to that as
Hmm.
no, we didn't get too much into it today. It's a very large
Hmm.
topic.
Hmm.
But do know that the methane levels in your bowels can also slow your transit. And it is actually the microbes in your bowels that make methane.
Hmm.
So they can impact that as well. One of the reasons we think that constipation almost feeds itself, like once you have it, it keeps getting worse, is because the essentially when you have a bowel movement, it's almost like the equivalent of brushing your teeth, kind of pulls a lot of your microbes out with it. Majority of your bowel movement is actually microbes
Hmm.
from your microbiome. And when they stay in there when we're not pooping, it will raise the methane levels and then slow your transit even further. So it's a little bit technical, but
Hmm.
that is a really common reason why we'll see it happen and why constipation can get a little bit intricate in its treatment.
Hmm. Well, can you tell people where to find you? So for the listener that is wanting some a little bit of guidance, where can they find you? And I will link all of this in the show notes, so don't worry about that, but just talk about it.
Fair. Yeah, so you can actually find me on my website. So that's my first and last name.com. And then also, probably the easiest way to get in touch with me is actually through my Instagram. It's where I interact with most people, and then I can kind of guide you to what I think would be best for you if you did want to work with me. And the Instagram, I'm sure you can link it there, as you said.
So do you mostly do one-on-ones? Do you do group education, online courses? Like what do you have to offer?
Yeah, it varies a lot. If somebody's in Ontario, then I will see them one on one as their naturopathic doctor. Outside of Ontario, I will do some one on ones, but I actually find constipation treatment does a lot better when you have a combination of one on ones and then online learning where you can learn on your own, you can digest things, you can generate questions, and then the one on one time is best kind of meant for us to go into deeper things and we use our time a little bit more efficiently that way. So that's kind of how I work with people outside of my naturopathic practice and instead in coaching.
Awesome.
Yeah.
Well, I appreciate your time so much and your knowledge, and I look forward to being able to use this when people come in and have some constipation issues. So thank you so much.